Beautiful morning to you. Thank you so much for tuning in this amazing Tuesday morning. It's the 26th day in the month of December 2023. How are you today? How was your Christmas celebration? I hope that you had a great time with family, with friends, with loved ones, well, even the people that you're not so cool with. Well, because you're in the same circle now, so you just have to hang out together. Anyway, it's Christmas, so just do it just because it's Christmas. All right. I hope that you had a very great Christmas, one to remember, at least for a very long time. Well, hoping that the things you remember are good things for this Christmas. Well, even if you kind of had a bad experience, don't worry. It's just one of those things. I'm sure that you'll get over it and try to avoid it next time. Basically, that's just what to do. All right, so this is Women Radio WFM 91.7, and of course, it's 6 minutes after 10 right here on Women Radio, Nigeria's first radio station for women and their families. This is the program Radio Doctor, your free health consultation program where real doctors advise real people. Radio Doctor is Nigeria's first specialized health program where medical doctors consult for free and advice right here on Women Radio WFM 91.7. Radio Doctor comes to you Mondays through Fridays from 10 to 11 a.m. Now, today is on women's health. Like we always say, every day is for a medical specialty. All right, Mondays we look at children's health. On Tuesdays, women's health. On Wednesdays, we look at general health. On Thursdays, elderly health. And of course, on Fridays, we go with general health again. So today being Tuesday, it's on women's health, and women's health on Radio Doctor is supported by ACT Foundation. My name is Rose Yusuf Kaiser, and our radio doctor for today is Dr. Collins Abolaje. He's an assistant medical director and fertility physician at St. Ives Specialist Hospital. Good morning, Dr. Abolaje. How are you today?
Good morning, Rose. I'm doing well. I'm fine.
All right.
How are you?
I'm okay. Compliment of the season. Merry Christmas. Oh, yeah, just tell us how your Christmas went yesterday, Doctor.
Oh, I wish you the same. Merry Christmas. Well, it was pretty much just on a modest level. Anyways, I went out after eating a lot of chicken.
Oh wow! Okay. That part is important. Yeah.
Right. Yeah. So basically, just had fun. Catching up with some friends and all of that. So it was good.
All right. So it seems that you have a very good Christmas after all. At the end of the day, because it's always good to have friends and families that you can spend time with at this period.
Right.
Yep. Yeah. All right, so that's Dr. Abolaje. He's an assistant medical director and fertility physician at St. Ives Specialist Hospital. And today, Dr. Abolaje will be consulting and advising on uterine adhesions. Yes, you heard me. Don't worry, just calm down. You'll get to understand what that is in a minute. All right, uterine adhesions are what we're talking about today. So when it comes to women's health, there are some terminologies you will hear, and sometimes you begin to ask yourself, Kilo Day, what is going on? All these things from where? But just calm down. We'll definitely try to explain all of these things. That's why the doctor is here, all right? And we get to understand it better. Most times, there are things that probably you've heard of or seen some of these cases, but you don't know that this is what it is called. So just calm down. Don't be deceived by the big names or how these things just come. But just relax. We'll definitely go through all of this. All right, the phone lines to be a part of our conversation today is 07000 917 917. 07000 917 917. Send us a text or a WhatsApp message on 070 317 56537. 070 317 56537. That is a number to send a text or a WhatsApp message to us today. All right, you can also follow us on all our social media platforms, Facebook, Instagram, X, and of course YouTube at WFM 917. Log on to our website www.wfm917.com, and then you can also download our mobile app WFM 917. You get to listen to us from any part of the world. All right, so like I said earlier, women's health on Radio Doctor is supported by ACT Foundation. All right, let's get on to it this morning with Dr. Abolaje on uterine adhesions. All right, doctor, so kindly break down what uterine adhesions is. Now, when we talk about uterine, we know we're looking at the uterus, we're looking at the womb. So, but when you now add adhesions to it, break it down for us so that we'll get to understand this properly.
All right. So, uterine adhesions simply means the formation of adhesive tissue or formation of scar tissue inside of the uterus. And usually, these may not be limited to the uterus alone, but can also spread down to the cervix. And they are actually a primary consequence of previous uterine instrumentation. Now, all these are grammars. Okay, anyway, so this is what it means. So basically, if anybody has ever done any instrumentation using anything inside of the womb, maybe as a reason to help clear out the womb, evacuate something from inside of the womb, then that person has already been put at risk of developing uterine adhesions. Adhesions, as the case may be, they mean scar tissue, just like a person has a wound on the outside of the body, and then the thing develops a scar that's more like repairs that damage that has been done on the skin, either by whatever injury, situation that the person may have found in him or herself rather. Excuse me. And so basically, these adhesions they can form, like I said, inside of the womb and also in the cervix, and they can now result in certain symptoms. About 2.8% to 5%, between 2.8 and 5% of uh, women who have uterine factor infertility, they are actually having this uterine factor infertility because of adhesions. About 2.8 to 5% of them they actually have uterine adhesions. And it is said that most people, in about 1.5% of women who have done HSG before,
Yeah.
we've come to find these uterine adhesions as part of their diagnosis. Yes, we know that people do HSG to actually check their tubes, whether the tubes are open or not, patent or non-patent. But then, in a bid to also check the tubes, we now have found that about 1.5% of women who come in for this HSG actually have uterine adhesion, and this is also adding to the reason, okay, why they may not be getting pregnant. So, this condition usually can be referred to as Asherman syndrome. Usually, when you say syndrome is like a compendium of a lot of symptoms or the presence of a condition with its associated symptoms. So, basically, it is called Asherman syndrome because for some people, they might have heard this same condition in three different dimensions. Either maybe when you visited a doctor, the doctor called it uterine adhesions, plain uterine adhesions, or the doctor called it uterine synechia, or the doctor maybe later called it Asherman syndrome. Usually, when a person is having scar tissue formation, which is uterine adhesions, now as the case might be, the person is having uterine adhesions, and then you're having some symptoms such as lower abdominal pain, scanty menstruation, or menstrual irregularities generally, and also infertility, then it can be termed as Asherman syndrome. So, in any one of these cases, and in any of these representations, then this is going to be what we'll be talking about now. Either anybody that wants to refer to it as Asherman syndrome or as uterine adhesions or as uterine synechia, we're still talking about the same thing, which is scar tissue formation inside of the womb. Now, it is important that I also state that scar tissue formation are a normal process that the body employs in a bid to heal any
Okay.
wound that is present in the body. It can happen outside or even inside of the body. It's still the same thing. But then inside of the body, it should not be present, especially inside of the uterus. I beg your pardon. Inside of the uterus shouldn't be present because the uterus actually has the endometrial cavity, okay, which has specific tissue that should be present there that would allow the monthly or what we call the cyclical menstrual bleeds to happen, and that would also allow for embryo implantation, which is what would lead to the woman getting pregnant. So the moment all of that endometrial cavity has been replaced, the tissue that are present there, those endometrial that has been replaced by scar tissue, then it has made that endometrial cavity infertile. It has made it non-conducive, okay, for embryo implantation or even also for the woman to have a monthly cycle. So just to add to this also,
Yeah.
about now, about it is said that about 5% of women who have recurrent miscarriages, okay, actually they are experiencing this recurrent miscarriage. They have these recurrent miscarriages because of the presence of uterine adhesion, about 5%
Additions.
of them. And
Okay.
then For people who have gotten pregnant and something happened, and then maybe they lost the pregnancy, and then they had to go in for evacuation, as case may be, in 13% of these women that will go in for evacuation, okay, they can actually develop uterine adhesions as a consequence of that evacuation that will be done for them in a bid to remove any remnant, okay, any remnant of the conception that they had.
Yeah.
So, and for some people, again, going in for fibroid removal surgery, especially for fibroids that are present inside of the womb, especially for fibroids that are present inside of the womb, okay, about 23% of them, 23%, that's a large number, about 23% of women who would have fibroid present inside of the womb would develop adhesions. And now, just to shock people a little bit, okay, for people who have had this fibroid removed from inside of the womb, now, like I explained the other time, the womb has 3 layers. You have the perimetrum, the myometrum, and then the endometrium.
Yeah.
Endometrium is the inner part. Anytime you hear endo, it means inside in medicine. So the inner part of the womb, which is called endometrium, that's where a baby stays and grows until the baby is ready to be born. So basically, anybody for some women, they have their fibroids not only on the outside, but they also have it inside that space where the baby is supposed to stay. So usually, for people who have gone ahead to do surgeries to take out such fibroids or polyps from inside of that endometrial cavity, they also stand a chance, okay, of having recurrent Asherman syndrome. They stand a chance of having the same Asherman, the same uterine adhesions. So basically, as a consequence of you trying to rid yourself of one evil, you are faced. The person is faced with another. Yes. So basically, it can really be very funny because, I mean, why proceed to do something that you also stand the risk of developing something else that would even be worse off than, that could be worse off than even
what
the
you
latter,
actually had,
or the former rather. Yeah. So basically, it is quite a very funny condition, but can really be serious and can really be the source of pain for a lot of people. When I mean pain, I mean good emotional pain because they're not getting pregnant, something that seems so easy to treat, and then of course the person is not getting any headway or not getting any breakthrough in handling it. It can really be,
all right.
Really be serious.
Thank you so much, Dr. Abolaje. This is Women Radio WFM 91.7, 17 minutes after 10, right here on Women Radio. And of course, this is the program Radio Doctor, your free health consultation program where real doctors advise real people. Do also dial the number 07000 917 917. Send us a text or a WhatsApp message on 070 317 56537. Today, Dr. Abolaje is consulting and advising on uterine adhesions. All right, so do well to call us with your thoughts, your concerns, because funny enough, Dr. Abolaje is saying this, and I'm actually learning a lot from this. So I'm hoping that you are also following on the conversation and also learning too. All right, because sometimes you hear if you don't have the right information, you might not know what to do or where to turn to for solutions. So it's actually good that we arm ourselves with this information. So do well to call in with your thoughts, your questions, and your concerns, especially on uterine adhesions. All right, so our doctor is here consulting and advising today on women's health, right here on Women Radio WFM 91.7. All right, so let's get on to it. The doctor has told us what uterine adhesions are and how. Well, now, doctor, you've told us that this actually develops from instrumentations that are being used inside woman's womb to probably do an evacuation and all of that. But these evacuations, are actually necessary in some cases. So, can a woman actually do without it, not to, go through or rather come up with these uterine adhesions? Because at the end of the day, you might go through some pregnancies, especially late pregnancy loss, and then they tell you that, okay, the only thing we can do right now is to probably, induce you after induction. They tell you, okay, we have to evacuate whatever remains there so that, you would be able to get pregnant again. But meanwhile, that is actually opening you to adhesions at the end of the day. So How does one get to manage this information? Like you said, you're trying to solve one and you're seeing yourself
Yeah.
maybe gradually entering into into another kind of trouble. So how do we
Yeah.
then go about this? Because there are women who have done
Okay.
this maybe once, twice, up to 3 times too.
Yeah. So basically, in a bid to try to run away from or try to prevent any like put yourself in a position where where the person would possibly in the future have uterine adhesions. Okay, certain things have to be put into consideration. So first off, the physician that's attending to the lady, to the
Hmm.
woman, has to have the right expertise in a bid to try to do whatever form of instrumentation, especially for dilatation and curettage. That's D and C, the one we call D and C.
Hmm.
Now, in the past, we used to actually do the D and C, where you dilate the cervix and then you use a curette. You know, a curette is like, I don't know, sometimes I try to use things that people can relate with, but it's an instrument that looks like a spoon. It's like a spoon,
Hmm.
okay? Just with a space, anyways, in the middle. And so basically, it goes in there, and then the doctor tries to just take out gently. It's actually done using a gentle approach. So you don't want to go in there as though you are a mechanic. You know, I'm very sorry to use that thing. Yeah, so you just go in gently, and you try to take out any remnants, okay, of conception that might have been present because you just want to do that to prevent infection, to prevent bleeding, and to prevent adhesion formation even. Okay,
Hmm.
so basically, so the expertise of the physician has to be taken into consideration, and also the doctor himself also has to do what we usually do it every time. It's like a permutation. You have to check between the risk and the reward.
Yeah.
Okay, the risk of giving this woman a possible problem in the future by doing that dilatation and curettage or doing that DNC or whatever for that woman, and
Hmm.
also talking about the reward. Okay, yes, if I do this, it's going to give her more. She's going to benefit more from doing it than put her in a risk. So you actually do that risk versus benefit thing. Okay, so basically, it is going to be left for the doctor to actually decide. And whatsoever, there are people that have done this dilatation and curettage, a couple of times, but maybe because of the over the top expertise of the physician.
Hmm.
It is done very well. Okay. And then, of course, the woman doesn't have any adhesions, even over after having three dilatation and curettage, not for unhealthy purposes, anyways, like people who terminate pregnancies, intentionally. No, this is for like the woman had a miscarriage and you just want to make sure that there is no remnant in there just to give
Yeah.
her the best chance of conceiving again, you know. So basically, these days, even physicians usually do not do the D&C, that conventional D&C,
Hmm.
okay, especially for after a miscarriage. You usually do what we call the MVA, manual vacuum aspiration. So basically, it's like a rubber kit. It goes in there with a vacuum mechanism, trying to aspirate everything that is present. Of course, there will still be some back and forth movement in a bit to try to empty the uterus completely. And the thing would actually give you a signal, like you would know when the uterus is empty, when the uterine cavity is empty. You would
Hmm.
feel there's a British sensation. So basically, you know that is the point to stop. But for some people, especially for people, maybe for medical officers, or that do not really have the experience, they could still be like, maybe they're trying to empty or clean out the uterus. It doesn't really work that way. When it gives you that signal of that gritty sensation, you know that this is the right time to stop. You don't want to be overzealous in trying to just empty the uterine cavity. So that's why I said the experience of the physician, of the handling physician, is also brought into book in a bid to try to give the woman the best service.
Hmm.
So, like I said, it has to do with the judgment. The doctor has to make a judgment call, of course, and also bringing his experience into light also, in a bid to try to help the woman.
Hmm. Okay. All right, thank you very
Yeah.
much, Dr. Bolaji, for that. Now, let's look at what symptoms might indicate the presence of uterine adhesions, in a woman. Because at the end of the day, we should be able to know that, okay, this might be the thing, why we're having this particular, result at the end of the day. So maybe it's as a result of uterine adhesions, that's why we're having this. So what are some of the symptoms that might indicate the presence of this in a woman's body?
Okay, so the thing with uterine adhesions is that um, not everybody who has these uterine adhesions will present with symptoms. So this also depends on the severity of the disease, or let's call it the staging now, just for better understanding.
Okay.
Okay, so there are three stages. You have the mild, moderate, and the severe staging of the adhesive of uterine adhesions. So basically, if it is in the mild stage, okay, these uterine adhesions only have taken, or more like encroached, about one third of the uterine cavity. Okay, so there are just some few adhesions in around one third. Take the entire volume. Just imagine the volume of the uterine cavity. About one third of it has been encroached. Just like a third of it. Like let's say, what's that? One third is like 30%. Yeah. Yes, somewhat around 30%. Yeah,
Yeah.
thereabout. So basically, has been taken over by adhesions, and they are scattered here and there. It's not like they are it's not like they are markedly expressed and all of that. No, they're just scattered around. Some few adhesions present in there. Okay, about one third of the uterine cavity. So for such people, they may not even present with any symptom at all. In fact, such persons might still even get pregnant. You still find women who bring in their HSG reports, or maybe whatever report, with the presence of, and the thing is showing that there's presence of uterine adhesions,
Additions.
some few scanty adhesions, and they're still getting pregnant without problems. In fact, they bring the report to you, you do whatever you have to do for them, advise them properly or do some induction for them, and they still get pregnant, with that same report. So basically, this is just to emphasize that not everybody who has the adhesions would have problems, would have any form of symptom. Okay, so about one third of it, like I said, some people will still have normal menstrual bleeds, or for some people they may start experiencing some scanty menstruation. Okay, so that is for some people. For others, for the moderate stage, usually these covers are between one third and two third of the entire uterine cavity. So in this case now, it is established that this woman would definitely, okay, have scanty menstruation. Now, when we say scanty menstruation, it's part of the symptom that is present when a woman has uterine adhesion. The reason is because the normal layer, that endometrial layer, it has a basal layer and it has a functional layer. Functional layer is a layer that bleeds every month. So basically, once this happens, usually it is injury to that basal layer that results in all of these things, that results in all of these problems, uterine adhesions. Now, when the basal layer is what gives rise to the functional layer that bleeds. So if there's problem with that basal layer, there won't be enough functional layer anymore. So the areas that should shed, the areas that should bleed will not be present, or would have been taken over by this scar tissue. So because of that, the woman will not have the normal volume of menses that she should be having every month. That's why you find some people complaining that, doctor, I started having scanty menses after CS. Because even people that had CS, they are also prone
Prone to
to having,
this.
you can imagine, yes, having CS to take out the baby, and then you're causing something that will not prevent the woman from getting the next baby. You can imagine. So this is just the irony of the entire thing. So then, for people that have the severe stage of this disease, usually they have very dense adhesions that are covered over two-thirds of the entire womb. And basically, such people would not even have menses at all. So that is also another symptom. The first we mentioned right now is scanty menstruation. The next is the absence of menses, because almost the entirety of that endometrial cavity has been taken over by this adhesive tissue,
Addition.
and because of that, of course, there won't be enough viable endometrium to bleed. Okay. The next thing that people could experience is pain. They could be having cyclical pain. Cyclical pain simply means that they'll be having pain as at the time when they're supposed to see their menses. So they have all the intense cramping and all of that, but then they are not seeing any blood. The reason is because for some people, like I said, like we made mention of earlier, the adhesions could have been found or can be found in the cervix. If the adhesions are found in the cervix, okay, now for instance, the adhesion is in the maybe lower part of the womb that leads into the cervix, and also covering maybe the internal os and all of that, the blood will not pass through. So the blood will accumulate inside of the womb. So usually these people, they could be having what we call hematometra, as the case might be, where there is accumulation of blood inside of the womb. The menses that's supposed to come out is formed inside of the womb, but it's supposed to flow out, but it cannot flow out because adhesion is present inside of the cervix, or in the lower part of the womb leading into the cervix. So this will result in the accumulation of that blood inside of the womb. So it is not going to come out. But the woman will be having all the cramps in the B2, because that's what happens to the uterus. The womb will try to have some contractions or cramping in the B to force out whatever is in there, but it's not going to come out. So this woman would only have cyclical pain, cyclical pelvic pain. For some other people, they could be having what we call retrograde menstruation. Retrograde menstruation simply means that instead of the blood to flow back out, it is just like an extension of what we just spoke about now. The blood will flow into the maybe into the tubes or even into the pelvic cavity.
Doctor,
okay? Because it's not going to come out.
These things are just sounding scary.
Exactly.
Oh my goodness.
That's why I said, when we mention the title, when we mention the topic, uterine adhesions, some persons might just be like, oh, it's something. Truly, it has. In fact, I've seen a woman who developed adhesions just because she had an evacuation. Okay, same thing. She had an evacuation for a missed abortion. She got pregnant, but in the early phase, the baby, the heartbeat went out. So basically, of course, they had to do an evacuation for her, and the doctor now placed an IUD. IUD it's one of those small devices that's placed into the womb to try to vitalize the womb, give a lot of nutrients, all the hormones to go directly into the uterine cavity. And then, of course, she developed adhesions. Just you can imagine, she developed adhesions, and then she came in for IVF because of that same adhesions. And such persons, even right now, okay, by reason of what we saw, okay, she might even be a candidate for surrogacy because the adhesions have actually taken over greater than 2/3 of that endometrial cavity. So the next symptom, like we said earlier, adhesions can be the cause of recurrent miscarriages for some women because the presence of the adhesions has reduced the space it takes for the womb for the baby to grow. Okay, so basically, it is not be compatible. That endometrial cavity will not be compatible for fetal development. So it can be the reason for recurrent miscarriage. And lastly, of course, can also be the reason for infertility, a delay in getting pregnant. It actually does this thing through 3 ways. First of all, it will prevent sperms from moving very well. Okay. The sperms actually need that same conducive environment to move. But when you have adhesions, especially like I said earlier, maybe an adhesion in the cervix, of course, the woman will just be having intercourse. The sperm will not be able to pass through the cervix. After a couple of days, they will die in that upper vagina area, and that is it. So adhesions can prevent sperm transport, can impair sperm transport. For other people, it can. The reason why they are finding it difficult to get pregnant, it is that the adhesions has actually prevented embryo implantation, the embryo from implanting. So if for those of them that do not have the adhesions present in the cervix, the sperm is able to pass through, get to the tube, fertilize the egg that was ovulated, okay, from the ovary, and of course, in a bid for the embryo to come back into the womb to implant. Of course, it doesn't find enough space for it to implant or any viable tissue available for it to implant in. And then, of course, the woman would not get pregnant. And lastly, even for people that they didn't have impaired sperm transport, they didn't have impaired embryo implantation, they can still have abnormal placentation because same thing, because of the presence of adhesions present in there. And this in itself can also result in either fetal growth retardation, intrauterine fetal growth retardation, and even miscarriages itself. So that is, I don't know if I've left anything out, but I think I've done justice to the symptoms.
Okay.
That are present.
All right, Dr. Abolaji, thank you very much for that. Do you want to call us up on 07000 917 917? Send us a text or a WhatsApp message to 070 317 56537. All right, that is the number to get in touch with us today. This is 27 minutes to 11 right here on Women Radio WFM 91.7, and this is the program Radio Doctor. And today we have Dr. Colin Abolaji with us. He is consulting and advising on uterine adhesions today. And of course, this is really, really interesting because I used to, when I hear additions, I would just think, oh, maybe it's just something, there's nothing more. Like, I didn't know that there's a whole world of it. Okay. But
exactly.
I mean, it's definitely something that we should all get to have more information about. And this will actually help you make informed decisions, at the end of the day.
Exactly.
All right. So, yes, do well to send in your questions, your contributions, your concerns right here to 070 317 56537. You can also call us up on 07000 917 917. Let's get, what's on your mind on this morning. All right, doctor, you have given us, the symptoms that this might
Yeah.
actually present itself with. So, now, how are these actually diagnosed? Is it only when maybe a woman is trying to get pregnant, or when she's having frequent miscarriages and then they get to check and this is it? Or maybe, when she complains that, oh, my menstrual period, I don't understand. Is it that very scanty? Or I'm having the pains, but it's not coming out, and all of that. So, how do we actually get to, how is this diagnosed?
Okay, so the first step, of course, is to understand the history of the woman. Basically, she's telling you, giving you pointers. She just tells you the symptoms, and these symptoms that she has said or that she has given will be like pointers to, thinking in that direction that she might be having uterine adhesion, especially for somebody who has had, previous instrumentations. Of course, this is what will give us pointers. So after taking note of that history, of course, the next thing, of course, is to do a transvaginal scan
Hmm.
or a scan, just to check the womb itself to be sure that there's no presence of adhesions. Because even on scan, you can be able to actually identify or to see, if there is adhesions or not. For other people, which is the commonest way, of course, for some women, especially those of them that have been trying to get pregnant, of course, is the HSG. They go in for the HSG to check their tubes. And
Yeah.
of course, in addition to whatever might have happened to the tubes, they will be given an extra diagnosis, with uterine adhesions. So HSG is one imaging modality to diagnose uterine adhesions. The next, of course, is hysteroscopy. Hysteroscopy is the one where you pass a telescope into, it's like a camera, it's an instrument with a camera. You pass
Hmm.
it there into the womb itself to have visual, to have direct visual observation of these adhesions inside of that uterine cavity. And of course, this can also help to tell the doctor about the extent of encroachment of that endometrial cavity. MRIs can also be used, but of course, for uterine adhesion specifically, hysteroscopy is very, very superior
Hmm.
to every other imaging modality. The others can only tell you that yes, there is presence of adhesions, but hysteroscopy will tell you about the extent. How extensive is it? Is it everywhere? Is it up to two-thirds, one-third, or the entire uterine cavity?
Hmm.
Okay, so yeah,
Hmm. Okay.
so yeah,
All right.
that's it.
Thank you so much, doctor, for that. At least we've heard how this is diagnosed. Now, what are the treatment options for this? Is it something that is easily
Okay.
treated, or you have to go through some sort of processes to actually get this treated?
Well, there are treatments for uterine adhesions. The number one is, of course, hysteroscopic adhesiolysis. Now, adhesiolysis, whenever you hear lysis, lysis simply means the breakdown of something. Okay, so it is hysteroscopic, means the use of this hysteroscope. You pass a camera into the womb and then you break those adhesions. Okay, it's just like using an instrument that has like a scissor to just try to shave off some of these adhesions. Okay, so that is the gold standard for the treatment, hysteroscopic adhesiolysis. But that is not all there is. For some other persons, of course, there's also what we call post-adhesiolysis care. So it is not just enough to do the adhesiolysis to break down these adhesions
Hmm.
using the hysteroscope. You also have to have a post-adhesiolysis care. Because if you do not have a post-adhesiolysis care, okay, you put that woman at risk of developing a recurrent, you know, adhesions, uterine adhesions. So basically, the adhesions you just took out, like I said,
Hmm.
okay, an adhesion will form again to replace that one.
Hmm.
Because these adhesions, they are formed as a result of the normal body's process of healing any wound that is created.
Oh.
All these instrumentations, whether for evacuation or not, whether you like it or not, a small injury has been created inside of the womb.
Hmm.
You do your MVA and all of anything that will result in bleeding from that womb itself, can
Yeah.
result in an adhesion. So let me just put that. It's safe to put it that way. So basically, the doctor has to institute what we call a post-adhesiolysis care, where after the adhesions have been broken, after the adhesiolysis has been done, medications can be given, hormone therapy, as can be given in the form of either the IUD devices and the rest to try to vitalize that inner space of the womb or to try to rid it of something that could possibly result in adhesion formation. And of course, we also employ the use of certain devices such as balloons to try to prevent the apposition. Apposition simply means the coming together of the different walls of that endometrial cavity. You just keep it in there for a while, anyways, just for a short period of time until the walls have been healed by themselves. And then, of course, the balloon will be taken off. And then these days, of course, people are also having what we call experimental stem cell therapy, where they are using certain medications or certain substances like platelet-rich plasma, growth factor to try to regenerate. It's just in a bid to try to regenerate the endometrial cavity to those endometrial tissue, those endometrial, the normal tissue that should be present inside of that endometrium. They're trying to use it to regenerate it. Yeah, so that's still an experimental thing, but I think in most part of the world it is being done, and it has shown some promises. So basically, that is it. Hysterosalpingo adhesiolisis as a treatment, and of course, institute post-adhesiolisis care. So I think that is enough to make some people attempt to revive their womb by having whatever adhesions that is present in there taken off.
Okay. All right. Thank you so much, Dr. Aboloje, for that. Please do well to call us up. Let's get to hear from you. 07000 917 917. Send us a text or a WhatsApp message to 070 317 56537. All right. Today is Women's Health right here on Radio Doctor, and is supported by ACT Foundation. And this is your free health consultation program where real doctors advise real people. So it's definitely open for you to call in with your questions, your concerns, or anything that you have in mind at all as regards to uterine adhesions this morning. So let's get to hear your thoughts, your concerns. The doctor is here to answer to all of it this morning. So we've talked, a lot about what these uterine adhesions are, how they develop, how we get to how we get to diagnose this. We've looked at the treatment, options available. We've also looked at, a lot of other things this morning. So, doctor, let's look at the risk factors. Now, you've mentioned quite a few, but I want you to actually maybe give it some few minutes, because at the end of the day, it's not like this is something that, let's say, you're born with, or this is something that just develops, or it's and it doesn't have anything to do with hormones, does it?
Well, primarily, no, it doesn't.
Okay.
But secondarily, because for certain people that have conditions like polycystic ovarian syndrome, where they have endometrial hyperplasia, and the doctor has to investigate them to try to be sure that they do not have any, maybe endometrial carcinoma in its early phase, or which is endometrial cancer now in its early phase.
Okay.
And usually there's something that we do as physicians. We usually do what we call an endometrial biopsy, just to be sure, that this lady is not having, endometrial cancer in its early phase.
Okay.
People can still develop adhesions from having endometrial biopsy done. Just biopsy is just an ability to take out a little bit of tissue from that inside.
Just by having that done.
Just for having that small biopsy. You just do. But there are different ways to take out the biopsy anyway. So in any which ways, the woman you can still put the woman at risk of having uterine adhesions. So that's why I said primarily no. But as a consequence of something that you just want to check, which is also part of the symptoms of having a condition, you just want to do biopsy just to make sure you tie all loose and to be sure that even a young lady or even the woman in her mid-30s or so, she's not, these days we're finding cancers in fact, even in kids, in children, teenagers and all of that, so basically you just want to check all of this to be very sure, and then you just put the lady at risk of having uterine adhesions. So the majority, the risks generally is that.
All right, let me just pause you a bit, doctor. We have a call. Let me just pause you a bit. Hello, good morning.
Hello, good morning.
Hi, good morning. What's your name? Where are you calling from?
Good morning.
Okay, my name is Ogechi. I come from Ogun State.
All right, Ogechi from Ogun State. Go ahead, let's hear you, Ogechi. You're welcome.
Okay. So the program this morning, I'm enjoying it.
Thank you. Thank you, Ogechi.
After giving birth, I started seeing my menses after 7 months. Then from there, but my menstruation was just one day and it will drop. I was confused. What is all this on? But normally, I used to have it 3 days and it will flow normal. But after giving birth, I did not have any miscarriage. And I gave birth normal delivery. So, but before I started seeing my menstruation, it's just a drop like this, just like that. So and I was scared. What is going on? So I want to ask the doctor the causes of it.
Okay. How long did you have this drop for?
For that 3 days, she just be dropping for that 3 days.
Okay, like for how many months did you experience this?
I got my baby now, and I started seeing the menstruation the baby when the baby just completed 7 months.
Okay, so you're saying that it was when the baby completed 7 months, your period has not been the same. You just see a drop.
Yes.
Okay. All right, Dr. Abolaji.
Okay. So now, basically, for her, now she rightfully said that she had a normal delivery. So basically, to stand on the side of saying that it is a CS that has resulted in that, because people who have CS can also present with this, okay, with this same complaint of having scanty menses and all of that. Of course, in this case, that is not it. In this case, that cannot be said for her.
Yeah.
So another thing that we can also look at as the cause of this is that she's breastfeeding. I'm pretty sure she's breastfeeding that child. And usually women that breastfeed children, especially, having a normal delivery and all of that, they should be lactating. So basically she's breastfeeding the child. And as far as you are breastfeeding your child, for some women, they may not see their menses even when it starts. They may not see their menses on time, and even when the menses will not return. That's what I mean.
Yeah.
Okay, and even when it does, it can start off as being scanty for some people, because their prolactin level is what is actually causing all the wahala. Okay, so for her, I don't think it's something she should be worried about. I think she should still give it a little bit more time, especially because it's just 7 months after she has delivered. In fact, we could even hear the baby crying in the background. So basically, I think for now, it shouldn't be anything for her to be worried about. Let her give it a little bit more time, maybe in the next couple of months, maybe within 3 months. If it still persists, then of course, let's see. But the truth is, if she's still actively breastfeeding, for some people, they will breastfeed a child like, they even go beyond the normal recommendation, So basically, all those prolactin, what a woman breastfeeding would have a high prolactin level, and this, of course, can affect the way our gonads, the way our ovaries senses these gonadotropins that are produced from the brain. And because of that, she may not actually be ovulating the way she should. And because you will need a developing follicle inside of that ovary to produce all the estrogens that will be required for the growth of the womb itself. So if she's not producing enough estrogen, maybe because the follicle is not really developing and all of that, or maybe, this would affect the way she bleeds. If the womb does not grow very thick, okay, she would definitely have scanty menstruation. It will be scanty because the womb did not grow to a very good thickness. So that can affect you. So my own advice to her is that she shouldn't be worried. Let her give it 3 more months, and then I believe everything will turn back to normalcy.
Okay. All right. Thank you very much. 07000 917 917 is a number to call. Send us a text or a WhatsApp message. 070 317 56537. All right, doctor, we have a WhatsApp message here, and it says, good morning. What could be the cause of everyday bleeding for 3 weeks after 4 months of miscarriage and proper flushing done in the hospital? We didn't get a name to this, but apparently now she has done, let's say, D&C or, in the hospital. And this was after 4 months, 4 months miscarriage. But she has been bleeding right now for 3 weeks. What could be the causes of everyday bleeding for complete 3 weeks after 4 months of miscarriage and a proper flushing done in the hospital? After 4 months of miscarriage,
of bleeding, so she most likely would need further evaluation, Most times whenever I say evaluation, I know a lot of people be like, doctor, your own says also evaluation. But it's the truth.
Yeah.
Yes, without evaluating her properly, we will not know what the cause might be. Just stating a few reasons, because one of the reasons that she might just be having a menstrual irregularity. Yes, that's it. Or now having to bleed for 4 months, bleed for 3 weeks in a
3 weeks.
four-month period, generally, like you're bleeding 3 weeks every month, 3 weeks, 3 weeks. Okay, that is already a sign that she has some menstrual irregularities. And basically, things have to be checked to be sure that she doesn't have any additional pathology. Things that could make you bleed for that long, maybe an endometrial polyp, or even a fibroid, inside of that endometrium. Okay, inside of that space where the baby is to stay and the baby stays, So basically, she has to be checked truly, okay, to be sure that there's nothing else present in there, because she said she had a D&C. Even if the woman had a D&C, as far as if she did it in a good place, of course, somebody that has a good practical experience on how to handle cases and things like that, of course, it should have been done very well. So I don't expect her to bleed for that long. But for her bleeding for that long, then I know a lot of people want to be like, yeah, maybe they made a mistake. The truth is, if it was done properly, there won't be any mistake, and of course, she won't bleed for this long. So she has to be reevaluated to be sure that nothing has been tampered with. But even if anything would have been tampered with, the truth is, adhesions would have formed, and that bleeding would not occur up to
No
this extent
call.
for 4 months. Yes, to not
Okay.
occur. So that's why I said something extra has to be checked. Maybe after all of that, she's now having, maybe by reason of stress levels and all of these things, she's having some, hormonal imbalance thing happening to her. And of course, these also have to be put into consideration so as to help her.
All
So let
right.
her, she has to visit the hospital again for proper
Hello?
evaluation
All
again.
right. So let's pick this.
Good morning.
Hi. Good morning to you too. What's your name? Where are you calling from?
My name is Glory, calling from Ogun State.
All right, Gloria. What part of Ogun State are you calling us from?
Okay. My question is, though I joined the program late, but my question is, how can addiction be treated?
Okay. All right, Gloria. What part of Ogun State are you calling us from?
Yanalogo.
All right. Thank you so much, Glory. The doctor has spoken about that already, but doctor, just in less than a minute, maybe we could just go over that again.
So, okay. All right. So basically, adhesions can be treated. We usually do what we call adhesiolysis. Okay. It can be done hysteroscopically for best results. But if it is a mild adhesion, usually some doctors can still attempt a blind, adhesiolysis, which is of course not recommended. It's not the gold standard. The gold standard is to do hysteroscopic adhesiolysis. They pass a small camera into your womb to visually see those adhesions, and then you use an instrument that has like a scissor tip to try to scrape out, cut out some of those adhesions present in any area that they are located. And after that has been done, of course, the doctor also has to institute what we call a post-adhesiolysis care by giving you hormonal preparations to try to make sure that the womb does not, grow so thick. Usually, we either pass an IUD or pass a balloon catheter, and of course, give hormonal preparations to try to make sure that you don't want the edges of the womb to come together again as part of the healing process. So you have to make sure that they are spaced apart. So it's part of all those post-adhesiolysis care. And lastly, there's also an experimental treatment that is done to try to regenerate the inside of the womb after all those adhesions has been shaved off.
Okay. All right. Thank you so much, Dr. Bolaji. Now, as we wrap this up, what would you want us to take home from our topic of discourse today? I know there's some things that we haven't yet touched, but in a minute or two, what would you want us to take home from the uterine adhesions of what, all we've spoken about today?
Okay, so basically, uterine adhesions, like we said, they are a consequence of previous instrumentation of the womb. So basically, it is important in some cases to have these instrumentations done, maybe to try to help out the woman and make sure that the womb is empty the way it should, so as not to prevent her from getting pregnant in the future. So it is important that when you visit your physician or you do any investigation and you are told that you have uterine adhesions, you also have to speak with your physician and ask what your chances are, especially if your own concern at that moment is getting pregnant. Ask very well, okay, can this level of adhesion, can it get me pregnant? Can I still get pregnant? Okay, because of course, like we said, there's always a risk of having adhesion formation when you do even the adhesiolysis in itself. So basically, you want to do that. And if your doctor is telling you that, of course, there's no other way out, then of course you might even still seek a second opinion. A second opinion in medicine is never ruled out. Even for us that are physicians practicing in this field of medicine, there are certain things that we would see. We wouldn't even make a unilateral decision. We'd have to call our senior colleagues or call people that have experience in, because in medicine, there's always somebody that has more experience than yourself in dealing with a particular condition. So it's very, very diversified.
Yeah.
So basically, you want to, of course, seek second opinion. So even for clients, I always am an advocate for second opinion. Is very important. And for additions, usually there's nothing like, let me just quickly do it, let me just quickly attend to it. No, that's why you can take your time in thinking about it, get all the information that you need from the first, from the physician, and also from somebody who has experience in it, and then make an informed decision. Yeah.
Okay. All right, thank you. So quickly, doctor, is it possible that if a woman hasn't gone through any sort of instrumentation, being inserted in her, or gone through any process that has to do with instrumentation, is it possible that she might just never come down with additions?
Yes, it is possible. Yeah. Now, there's a reason why I'm saying this. But of course, if the woman has gotten an infection, maybe having things like genital tuberculosis, or having schistosomiasis, these are some infectious diseases, of course. Of course, she can still come down with adhesions.
Okay. All right.
Yeah, and even with certain conditions also like endometriosis and the rest, she can still present with adhesions, because anything that will result in the inflammatory response within the wound in itself, of course, can on the long run result in formation of uterine adhesions. Even normal conventional endometritis, by some of these bacteria that we know here and there, of course, can still result in adhesion formation. Yeah.
All right. All right, thank you so much, Dr. Apology, for being able to be on the program today. We really do appreciate having your thoughts on all of what we've spoken about today. Our time is fast spent. We can't take any more questions. So thank you so much, Dr. Collins Apology, for being on Radio Doctor today.
Thank you for giving me this opportunity.
All right. So do enjoy the rest of your day and the rest of the holiday.
I wish you the same.
All right, thank you.
All right.
So that's where we will drop the curtains today for the program Radio Doctor. Join us again tomorrow at 10. I was about to say 9, at 10 a.m. All right, so a very big thank you to our Radio Doctor for today, Dr. Collins Abology, and for you also tuning in and listening today, and to all those who called. My name is Rose Yusuf Kaiser. Do have yourselves a great day ahead and enjoy the Boxing Day.
WFM 91.7.